Hello everyone, welcome to my channel of Lighthouse Pharmacology. I'm Yuan. So in this particular video, we'll talk a little bit about organ toxicity. So bear in mind the material prepared for this particular video or this class, it's mainly targeted for a first year pharmacy student, and whereby the content of this course is actually embedded as part of the basics of pharmacology course. So therefore it's not good enough in a way or in-depth enough for a toxicology course, just bear in mind. So this video will be like an introductory video or to cover an overall picture on specific organ toxicity, namely the liver, kidney, lungs, and brain. Right? So the main question that we're trying to answer is that how could different substance induce toxicity in these specific organs? When we look at the overall picture of the toxicity for the specific organs, so we actually need to look into the different factors that actually determine if an actual toxicity can occur. Because bear in mind, different people, for example, has different susceptibility towards certain toxicity. Right? For example, if a person is exposed to a certain toxicant at the same time, so person A and person B, both of them may have the toxicity symptoms, but it may have different severity, for example. So one of the key factors is about accessibility. So for the person to get toxic due to a substance, right? In this case, we cover different substance, so it's not just about drug substance only. So for different substance, so the substance or toxicants per se needs to be able to reach that particular organ, for example. So we talk about accessibility, so therefore remember the different organs that we talk about just now, which covers liver, and kidneys and different organs. So the substance must be able to reach the target site, similarly like the drug analogy, so that it can exert its toxic effects. Right. Another part is about the quantity of the toxicants. So obviously, similarly like the drug concept as well. So the higher the concentration or the amount of the toxicants or substance that can reach the site of action in a way, so the extent of damage caused will be obviously more severe, right? Because there's higher concentration, so there's a greater exertion of effects, right? And another part that we need to consider is the differences between the different organs. For example, so certain organs, for example, compared the liver to the brain, right? So obviously the liver cells probably would have a higher or faster capacity to repair itself. So again, it depends whether the toxicity is an acute one or a chronic one, for example. So if it's a chronic one, if the concentration may not be at highest, so the body is actually sufficient enough for its protective, for example, antioxidant mechanism and so on, that could actually repair the damage over time. So therefore, an acute toxicity event may not actually occur in the short period of time. So another part is about the pre-exposure health status of the individual. So for example, if the person has already have an underlying liver disease, for example, so that particular person's liver function is obviously not at its optimum compared to the normal healthy individual. So therefore, if there's exposure towards a certain toxicant, which is going to further damage or reduce the liver function, so obviously the person will be more susceptible to the toxicity, i.e., so the exposure concentrations to the toxicant may not have to be very high, but for the person who already has liver impairment, so the person would actually start to experience toxicity effects, whereas the normal population individuals may not yet. Right. So there's another part about toxicity, i.e. is like side effect stuff, which is something called idiosyncratic. So where the term actually means that we don't really know why actually. So some stuff in a way, or some toxicants actually cause toxicity or damage to certain cells in different organs, right? But we don't really know why, right? So, and it's only applicable for certain individuals, but not all. So this is still something that we don't really know what's the reason. So we are sort of like idiots. So therefore comes in the specific scientific term of idiosyncratic. Right, so bear in mind, the last point here of systemic effects, i.e. refers to the overall body effect. So this is the point is added here as a reminder that even though we mainly talk about specific organ toxicity, but obviously all of our organs are connected, right, by the general blood circulation. So the effect of toxicity might be more profound or more obvious at certain organs, right? But it doesn't mean that the effects can only be seen at one place but not the others, because the toxicants or compounds obviously has a capability to travel around the blood vessels, so therefore different organs are also exposed to its toxicity effects. So when we talk about toxicity, so the second main question that comes into place is about prevention, of course, because always prevention is better than you have to cure a toxicity, right? Same concept like a disease. So what is the best prevention methods that we can use? So again, this is a general picture. So the first one is if we already know that the person is having a certain impairment, for example, like liver or kidney, these are the two main ones, or decreased lung function, and things like that. So the best way is we can actually reduce the dose, right? But bear in mind, these type of prevention methods are mainly on the things that we already know that things is a toxicant. If there's lots of stuff that we actually don't really know its identity being a toxic substance, so it's a bit more difficult to sort of prevent because we don't really know what to prevent. So if it's a known substance or a drug, right, for example, then you can actually do more straightforward prevention methods like reduction, dose reduction. And another part is for those which are very, very toxic in a way, or the impairment is very, very bad. So one of the best way that we can do is just to avoid it altogether. So in terms of the drugs, we can actually suggest alternatives. So i.e., probably the next question you might ask is like, what drugs do you actually need to change the dose or to avoid? So it's always easier to check different drug references. So it can be drug information booklet, BNF and things like that. So if you actually have a case of an individual with a certain like liver or hepatic impairment, so you can actually double check, cross check all the drugs and the doses of the person is taking, so you can, as a pharmacist, to avoid drug-induced toxicity in this case. Right, so this is an example, like if you can see in the BNF. So this is from BNF. So there's a section here called, under hepatic impairment. So you can see that in this case for blecometasone, which is a type of steroid, the manufacturer advised avoid in severe impairment. Right, so this drug, you don't have to do a dose change for renal impairment, so therefore it's not, it doesn't appear here, right, for renal impairment. Right, so after all the general introductory stuff, so now we'll move on to the specific organ toxicity. The first organ, remember we have to cover 4 different organs in this video. So we've got liver, kidney, lungs, and brain in a way. So the first one that we're going to go through is liver toxicity, or the more scientific term, it's also called hepatotoxicity. So as we all know, based on your basic information in pharmacology, liver is the main site of drug metabolism, right? So you have your main biotransformation and things like that, and you got your cytochrome P450 and all. So it's the main site of organ of detoxification. So based on its function, so we already know that there's a lot of blood vessels, and all the drugs or all the substance that actually gets into our body, into the general systemic circulation, no matter you take it in which way, somehow sooner or later it will reach liver. So therefore, liver is one of the main site of susceptibility. Therefore, the susceptibility of a substance, right, to be hepatotoxic, if a substance, if it's to have toxicity to certain organs, so liver is one of the main one, right, or the main possible site of toxicity, right, because it definitely has to go through there. So when it's in the organ, it can do some damage. right? So because it's the first stop, right? So before it goes through any biotransformation, you know, or detoxification, metabolism, it has to go through here first before it's being exposed to other organs. So it's the first stop via hepatic portal vein if you're talking about the normal ingestion through the GI tract one. So, and also it's also the site of the gathering, in a way, of the concentration of lots of different subtypes of cytochrome P450. So therefore you can imagine, in a way, biologically there's a lot of probably more reactive or more toxic intermediates of a substance which can be found in the liver, which has the potential or could cause damage. Another part is hepatic recirculation, which refers to the enterohepatic recirculation. So for certain drugs, it can be excreted through the bile and then goes back into the liver again. So there's a halo, in a way, or meeting up the toxic substance in the liver again for the second time. So again, the more the organ sort of sees or meets the toxicant, in a way, so there's higher chance of damage to occur. Right, so you can see here in liver disease, so it may alter the response to drugs. So therefore, if the person has severe liver disease, so you may need to, you know, avoid certain drugs altogether, right? And it can be seen in people with especially other symptoms of liver disease like jaundice and so on. So before we delve further into the specific liver toxicity mechanisms, so just have a brief overview about the anatomy about the liver. So again, like any organ is full of different cells, right? So the main one that we talk about is hepatocytes, right? So you can see there's different blood vessels, you know, it's full of blood vessels and hepatocytes in between, and also these are places where a lot of damage can occur, and there's also immune cells per se to actually protect the liver under normal circumstances. Okay. So again, this slide is also an illustration of the different cells available. So again, the hepatocytes and different branch, and together with the bile duct and so on. Again, as a reminder on the physiology of the functions of the liver, so as you can see, there's lots of major functions like protein synthesis, again our favorite, in a way, metabolism of bioactivation. You've got your bile secretion, and also there's lots of things involved in the middle, right? Examples of substance involved. And if there's impaired function, so what will happen? So as you can see here, this is again just as a reminder that if liver toxicity occurs, so it actually has multiple effects, systemic effects on the body system. For example, you can see hypoglycemia, right? They can have you know, diminished drug function, jaundice, and so on and so forth. So again, if it's too severe, liver transplant may actually need to be considered. So this is a summary table on all the stuff, in a way, that you need to know about the toxic response of the liver. So as the chart obtained from the Caseret toxicology textbook, in a way. So as you can see here, there's different types and mechanisms of liver injury. So some are just simple cell death, some are bile duct damage, some you can cause fatty liver and all. Fibrosis is the one that we try to avoid because it's quite irreversible based on from drug action, and it can also have tumors, right? And there's also different factors that can determine whether how huge or how terrible is the extent of damage. So as you can see, these are the critical factors, like for example, how what's the extent of inflammation generated due to the exposure of the toxicant per se. In this table, it's a summary of the types of injury of damages, which is mentioned in the table above as well. So, but here we are also adding on the representative toxins, which can cause the respective type of injury or damage. So for the purpose of exam, it's not required for you to remember the whole list of the toxins that can cause which type of damage, but this table clearly illustrates that there's different types of toxins that can actually cause different types of damages, right? There's a whole exhaustive list of them, and there's also some which can cause multiple ways of damage to the liver as well. So as you can see here, there's lots of names. Some may be more familiar to you, right? Some maybe not so. As you can see, some are more rarely to be seen, which are known toxins. Some are heavy metals, some are more drugs, or ethanol and stuff like that. So basically, the mechanism of toxicity, the details of it actually differs, right, based on the structure and so on for each drug. Therefore, it's like a story. It's like a storybook literally for each different drug. Similarly, like the concept of each drug in a way that you learn in the class has different ways, different mechanism of action and so on. So nevertheless, there's also some important players that can cause injury. One of it is free radicals. So bear in mind some of the drugs, some of the toxins or toxicants, they can actually cause stressful conditions within the cells. Some of the mechanisms are clearly known, maybe through the mitochondria, etc., damage, and things like that. Some actually we don't really know why, and it's a more generalized, non-specific effect of damage that we see. So one of the ways that it can cause is via free radical generation. So as you can see, the accumulation of free radicals can actually cause a lot of damage to all the different parts or the functions of the cells, therefore ultimately can cause cell death and etc., damaging effects, and some may be irreversible, right? In this slide, we'll actually look at some of the drugs that which are more commonly seen that can cause hepatotoxicity. So one of it is paracetamol, which I won't really go through a lot of details in terms of its mechanism, because I think it's repeated multiple times in the whole module of toxicology, basics of toxicology in a way, where to treat it you need N-acetylcysteine and all. Another one is alcohol. It may be a chronic damage rather than acute damage most of the time to the liver. So there are also some drugs which can cause idiosyncratic hepatotoxicity. So what it means is that it can be allergy based, it can be non-allergy based, but most of the time it's a very individual specific response, whereby it's not that everyone on diclofenac would experience this and so on. So it's a little bit like allergy, side effects, whereby not everyone would get it, so which makes its detection a bit more tricky sometimes, right? So anyway, if a person, as a general rule of thumb, if you're trying out a new drug, so you just have to monitor a little bit more in a way. So within the first half an hour to first few hours, you just have to see whether there's any uneasiness or something is wrong that you want to detect. If there's anything suspicious, again, just go and visit the doctor, or just rush to the hospital just to be safe. Okay. Here is a reminder on what's the impact of all the toxicity and stuff under liver toxicity towards prescribing. So this is a section from BNF itself, where there's some points to note in general, right? So you can see if there's hepatic impairment, so the person would likely experience hyponatremia, reduced clotting factors, impaired drug metabolism, hepatic encephalopathy, right? And fluid overload, right? Which therefore you might need adjustment in dosage. And there's also hepatotoxic drugs that I would like to highlight. As you can see, most of the time it can be dose related, so it's more like a predictable response, or the unpredictable, which is the idiosyncratic, with the examples as shown in the earlier slide. However, there's also it kind of be more frequent in patients with liver disease itself. So sometimes you might just have to avoid some of the drugs or to use it very, very carefully. So the big question here is that how do we monitor liver health? So bear in mind, if you're using when the physicians or the doctors are initiating a medication which has higher risk of causing hepatotoxicity. So normally what we do is that before the initiation of the drug, we will have to do a blood test to actually monitor the liver health parameters, the liver enzymes, and then later on, after 3 months, or or the next follow-up 1 month, depends on the drug. So we have to just repeat the blood test again and monitor if there's any changes or increase in the liver enzymes. If there's and there's a specific guide or parameter based on different drugs, right? Then if sometimes you might just need to reduce the dose, for example, again depends on the clinical response as well. And sometimes you might just need to switch the drug altogether. So back to the question, how do you actually monitor liver health? So the easiest way is to monitor the liver enzymes. Do you know the name of the liver enzymes? So some go and find out the details. So one of it is AST, ALT, and things like that. Okay. Next, let's move on to the second organ, which is the kidney. So kidney toxicity is also called nephrotoxicity. So as mentioned, it's probably an organ that you're very, very familiar with, because in the pharmacokinetic section, you already know that with the ADMEM metabolism involved in the liver, and now it's on the E side, mainly involved in the kidney, which is on the elimination. So there are different factors which actually detect or determine that kidney itself is also an organ which has high susceptibility towards toxicant effects. Why? So the first one is on the high renal blood flow. As we know, renal is a small organ, so if you actually look at the calculation on the amount of blood that goes through, so it's like the volume per kg of the organ. So obviously kidney would be the first, right, because it's small, but obviously all the blood will go through the kidney for filtration, right, to clear any rubbish in a way, or toxics or extra stuff, ions, extra water out of the system. So therefore it's also higher in terms of the quantity as well, in terms of the amount or the compounds that goes through it. So therefore it is susceptible to damage. Second is the concentration of chemicals. So again, it's an organ that has a concentrating function, whereby obviously the urine has to go through concentration. If not, we're going to lose a lot of water. So again, the concentration of urine with a lot of water, a lot of sodium reabsorption, water reabsorption, again will cause the concentration of the chemicals or the toxicants or compounds to be higher and concentrated within the kidney per se. So therefore there's higher effects or higher risk of damage to the nephrons, right? So, and there's also reabsorption and secretion of chemicals through the tubular cells, so again causing a high localized concentration of chemical on the site. And there's also some level of biotransformation, i.e. due to the presence of some of the cytochrome P450 enzymes. So bear in mind, as a recap, the main site of cytochrome P450 enzymes is in the liver, but there's also some peripheral cytochrome P450, some in the gut, for example, some in the kidney, some in the lungs, and so on. So those are the more rarer and not so abundant subtype. Right, so based on the information in the BNF, so if it's renal impairment, so you can see that if the person has reduced renal function, so obviously there's a lot of issues that comes together with it, similar like the liver example. So there's liver impairment, there's a lot of liver related issues. So over here, if there's people with renal impairment, so you might have to again reduce the dose for some of the drugs, especially those which are more water soluble, that has higher percentage of excretion through the kidney, and sometimes you might need to use alternative drugs. So again, these are for examples that to avoid toxicity for known substance, such as for the drug related, but again there's a lot of other non-drug related issues which is a bit more tricky, right? And there's also issues where people who have post-renal transplant, or or they're on dialysis, and also they might be on immunosuppressants as well. Over here in this slide, it's just a rough reminder on the overview on the structure within the kidney. So as you can see, there's different layers, right? And you have the nephron, the overall nephron structures, and obviously it's heavily vasculated, right? And that's for a lot of reabsorption and absorption and secretion of ions and molecules that occurs around the nephron. So to quantify everything, it's again a reminder of the function of the kidney. So as you can see, these are all cells in a way, so where the damage could occur. And there's also filtration, reabsorption, and excretion, and so reabsorption by the kidneys per day. So you can see this is per day, so it's over 24 hours. So there's a lot of movement of stuff going on. So depends on the structure of the compound that we're looking at in terms of the toxicant. Like for example, one of it may be lithium, for example, lithium Li, which is quite similar structure as Na sodium. So this is where they can compete for the same transporter and all, and then it can cause its own toxic effects as well, and accumulation and damage towards the kidney. That's one of the examples. Over here again, we'll look at the overall summary of the toxic response in a way for nephrotoxicity. So there's a little bit of anatomy and physio that we try to talk about, and again some susceptibility to the site, specific site. Some of it is more specific towards different sections of the nephron, for example. So depends on where it can be concentrated more, but some of it is more generalized. And the mechanism or effects, it can be cell death, there's mitochondrial effects, etc., etc. So and there's all sorts of different types of nephrotoxicants as well. One of the effects of nephrotoxicants, in a way, it's illustrated in this diagram. So whereby this is the first diagram over here, refers to the intact, right, the intact cells when there's a lot of extra gaps that we don't want, because that will obviously affect the kidney function in terms of its efficacy of its filtration, right? And there's also some, if it undergoes certain damage, so there might be some cell death towards the cells. As you can see, some may undergo apoptosis or necrosis, i.e. they're half dead. So there might be some infiltration of your immune cells as well that comes into place. But bear in mind, these are very fine tubes, they are very tiny ones, so they can actually cause scars and obstruction for the process as well. So this is one of the ways that it can actually reduce the kidney function in a way through injury to the renal cells. When we put all the mechanisms of reduction of GFR in a way, so whereby a reduction of glomerular filtration rate, GFR, refers to a reduction or a decline in the renal function. Okay, so over here, as you can see, A again is the normal one. So this is mainly, we look at the glomerular filtration process. Okay, so in the normal circumstance, so this is afferent, and then everything can pass through normally. Extra stuff will go through, but there are some issues whereby they can have reduction. So one of it can be due to constriction, so therefore the pressure is reduced, so it cannot go through much. Some is through obstruction, and sometimes it's through leakage, right? So these are the different underlying mechanisms for the reduction in kidney function. So details of all this, you go through more of it in your third year when you're going through your clinical and pharmacology of drugs on the renal. So based on the toxicology textbook, so these are the list of the different chemicals or drugs, right, that can actually cause renal failure in a way, or reduction in renal function, right? Some can be more on the filtration, some may be different processes. So for example, some on the pre-renal, some on the vasoconstriction side, crystalluria, tubular toxicity, endothelial cell injury, glomerulopathy, so i.e. there's some inflammation, and also some nephritis, another inflammation as well. So over here, I'm just highlighting NSAIDs because it's the first year course, right? All these drugs are important. For example, aminoglycosides are important as well. These are very potent antibiotics used in IV, but if there is a dose-dependent effect, right, that can cause nephrotoxicity, and its nephrotoxicity is sort of irreversible. Another one that I want to highlight over here is NSAIDs, which is the non-steroidal ones, anti-inflammatory drugs. So bear in mind is one, if a person use it at high dose for a longer term, sometimes obviously it's unwanted, because most of the time people use NSAIDs to control pain, right? Sometimes it might be sleep disc and things like that, which produce extreme pain for people, but therefore it's still required to monitor its duration of use and its concentration used, because at higher concentration it can cause damage to the kidneys, therefore one of the reasons of acute renal failure. Now we'll look at the impact of renal impairment in the prescribing issues. So again, this is from BNF. So some of it, so side effects are poorly tolerated. Some effects are not some drugs are not effective. Reduced excretion that may cause toxicity because there's too much accumulation of the drug in the body up to a toxic dose, right? Some might be increase in sensitivity. So again, similar back to the general principle that sometimes you might need to reduce the drug dose, right? And sometimes you might just use alternative. So this, in a way, it's also from the section. So sometimes we just have to avoid it. Of course, most of the time, if you already know that certain drugs are nephrotoxic, so we try not to use it at all in people with renal disease. So there's something that is noted over here, which is eGFR. So this is something that you can use to monitor the level of renal damage or renal failure, right? Some is just mild, some are moderate, some are severe, as you can see based on it. So this tries to answer our main question in a way whereby how do we actually monitor renal health. So remember that earlier on in the graph, one of the things that can be excreted and also some of our ions, remember, and one of it is creatinine. So there's something you can calculate based on the creatinine clearance. So there's formulas again, I won't mention because it's not really under the scope for this particular class, because the main thing that you need to know is from there's some calculations that you will learn as well when you're in your higher years, because this is just for first year, whereby you can see there's different outcomes or levels of or severeness or severity of kidney failure. So some are normal or high, so you can see some are moderate, some are severe. So you can see for different levels you may need to do different dose adjustments based on the drug that the person needs to be on. So this is something to remind. And again, remember the graph that we talk about one of the ways to reduce in GFR. Again, this is just an overview. So there's direct damage to the vascular due to factors such as inflammation, right? Some due to extra vasoconstriction and so on, that eventually can cause decrease in the pressure and all that reduces the GFR. Thank you for staying with me. So now is the third organ that we're going to go through on the toxicity. So just now we went through the details on liver and kidney, and now it's the third one on lung or pulmonary toxicity. So from the name or from logic in a way, so it's an organ which is more exposed, because obviously we breathe in directly, we inhale all the time and exhale all the time to keep us alive, right? So the toxicants that we talk about in this sense are mainly via inhalation that can get more direct exposure to the lungs, right? So most of the time in this case it's actually toxicants in a way, not really drugs in a way for most of the cases, right? It's more from the environmental, and some of it we learn it from more painful experience, because previously we may not know that some of the substance may cause such a toxicity effect. Some, because most of the things, if you look at the lung one, it may be more the chronic side, because due to longer term exposure accumulation, which eventually cause a toxicity effect. Because some of there's also acute ones but they may not be that common. So here again, we look at the anatomy first, right, as a reminder. So obviously we know this is the lung structure, and there's alveoli, so there's a lot of air sacs in the way, which should remain clear, right, so that there's no mucus or whatever, or no cell death that actually impairs the exchange of gas, right, that for the efficacy of gas exchange, right. So you need more workable, in a way, alveoli in the whole system. Right, and again, there's a lot of thin layers of cells in between that ensures the whole thing works properly. When we look at the overall summary for the things that we need to learn about the toxic responses of the respiratory system, again extracted from the Casseret book. So you can see that there's general principles. So there's some determinants that this sort of determine whether how bad it will be the toxic effect to the lungs. So there can be acute response, as mentioned just now, right? Some edema, and things like that, reactivity, so that mean bronchospasm, right? And there's also oxidative stress, right? There's also chronic response like fibrosis, cancer and things like that. So there are some agents that we know to produce lung injury. So these are the examples, and some of it are things which like asbestos, like previously it's used in the ceiling, but now obviously we know that it can cause long-term toxic effects to the lungs, so therefore it's not used anymore unless for those really old building that is not replaced, right? So, and there's also some evaluation later on. One of the mechanisms of lung or pulmonary toxicity is via inflammation. So you can see the outcome of inflammation is obviously there's an hyper response or heightened response of immune system, right? There's a lot of growth factors and things like that towards secreted by the macrophage to the system. So some of it is that in some of the cases we can actually repair the effect, right? As you can see, so it sort of goes back to the normal physiological or anatomical condition. And so it's sort of like, okay, the danger's over. So but under certain circumstances it might develop or proceed to develop into fibrosis or emphysema. So you can see here fibrosis again is not a good thing, because it's a lung which is an expandable organ, so we don't want any fibrosis which can cause the whole system to be stiffened, so therefore you can't really expand much, so therefore the air intake into the lungs will be impaired. So again, there will be a lot of excessive secretion of growth factors. As you can see, there's a lot of immune cells involved as well. One of it is macrophage, but there's also other neutrophils, etc., etc. So one of it, in this case of emphysema, is actually due to breakdown of the cells of the alveolus, so which is due to excessive secretion of proteinases. So proteinase, i.e. things that breaks down the protein, and therefore causing lesser cells within the system, right? So again, the gas exchange process will be impaired. As mentioned earlier on, so most of the toxicants that we talk about, one of the examples are mainly towards the industrial toxicants, right? So whereby it's being produced longer term, so therefore it's sort of like there's an occupational link towards those who are more prone to get this pulmonary toxicity. So as you can see, it's mainly occupational because it's mainly used in the production site, for example, in the factories. So they may cause some acute effects, right, and also some chronic effects as well. There are some extra considerations in terms of the extent of pulmonary toxicity that can be caused by a certain substance or gas in a way. So in this case, it can be particle size, some of it's particle shape, right, which we're going to look at later, and something like partition coefficient that we're going to look at later as well. So these three additional factors is something that we're going to go through for the following slides. So particle size and shape has always been a very important factor to be studied in the pharmaceutical field, right? So whereby when you want to deliver a drug, so you especially nowadays when we look at more into the nanotechnology and things like that. So all the size range that we look at is getting smaller and smaller. So what we need to understand is that the level of the drug or the substance in this case, because it's something that we know most of the time for fibers, sometimes it's something that we don't know, of course. Because the particles, small particles, it may exist as fibers, which are longer strands. Sometimes it might be, more, smaller circle stuff size. So depending on the size of it or the diameter of it, if it's a fiber, so if it's smaller, it can actually enter deeper into the lungs. Sometimes if it's bigger, it might be more deposited towards the upper part of the respiratory tract. And sometimes if it's too small, we can't really clear it out readily with our own existing physiological respiratory system, because obviously we have the the brush border a little bit, cilia and all that can push things and clear things out of the way, like how our normal mechanism of clearing out any phlegm after we get a flu, right? So in this case, when we look at the asbestos, so as you can see here, if it's 5 micrometer long, so sometimes you can get lung cancer with bigger ones because maybe it's too difficult to clear it out. So when it's larger than 3 micrometer, micro m, it does not readily penetrate into the peripheral, right, and things like that. If you have further development, it has to be even smaller and things like that. So again, nanoparticles will be even smaller size as well. So when you can see here, this is one of the diagram. So the first one over here is 5 micro m, this is 1, and this is 0.1. So you can see it just goes through deeper through diffusion. Sometimes it's just by impaction, because the first thing you saw inhale, so you saw a deposit. If it's big enough, you sort of deposit back in our throat-ish area directly through impaction, and later on when it's a bit it's bigger, right, then it can also go down by sedimentation, because by gravity, and it slowly just settle down. So when the size is smaller, it's mainly through diffusion because it's just too light. Next, we look at particle shape as mentioned. So this is the lung macrophage itself. Macrophage is about 12 micrometer in diameter. So you can see here, depends whether it's a fiber or particle diameter. You can see if it's getting bigger in size in this case. So if it's smaller, along the way there's higher ROS, which is the reactive oxygen species, so it means that there's more oxidative stress and toxicity per unit mass. So the smaller is it, there's higher risk of generating a toxicity effect. So a little bit opposite in a way for this side. So you can see if this is based on the length, not really the diameter. So the longer it is, there's increase in toxicity because it's sort of deposit longer, right, in the system. Moving away from particles, so we'll go back to normal gas. So the different gas, as mentioned earlier on, due to the industrial kind of exposure. So you can see there's something called partition coefficient, right? So some with high water solubility, so it might go on the higher side, right? So if it's a low water solubility, it tends to go further in. Okay, so that's why for different types of gas, there's the main site of injury would be different. This table, in a way, we're trying to look a little bit about pneumonitis. So again, it's more an inflammatory kind of condition, but this is more on hypersensitivity. So in this case, we can see that there's different agents. So over here, I'm just trying to highlight that different types of infection, for example, from moldy stuff and things like that, can also cause lung diseases in a way. So i.e. it's also a toxicity response, right? So some are from from plants, and animals and things like that. So again, these are more, as you can see, things like maybe paint refinishes lungs. So these are more things that we realize much later, due to historical reasons. Only we learn it much later, because things like isocyanates is things like solvents and stuff that we add into paints and plastics. So then over years only we realize that painters actually has higher risk of getting all this lung toxicity, then they go back and find out that, okay, so this is the substance that can actually cause all this effect. So therefore, these toxicants are removed from the current formulation. Hooray, hooray! We are at the fourth, which is the last organ that we're going to talk about, which is brain toxicity or neurotoxicity. So in the brain, there's something that we need to take into account. So obviously there's the central nervous system, which is the brain section, and there's also the peripheral nervous system, which refers to the nerves which are out away from the brain. So every nerves outside, that connects our hands, and legs and so on and so forth. So in the CNS, so again, remember the main principle of toxicity or toxicology is that your substance of culprit, i.e. the toxicant, must be accessible to the site. In this case, for central nervous system, the substance that can cause toxic must be able to go through the blood-brain barrier. So either the compound is very lipophilic, or somehow there's mechanisms or active transport and stuff that it can hijack into and then to go enter the brain, therefore causing neurotoxicity. If not, there's no chance for the toxicant to get intact to the nerves, right, or the neurons. So another situation is whereby maybe there's some inflammation at the blood-brain barrier. So again, there's more gaps, so there's higher risk of all the the toxic stuff to go through. Another part is also the peripheral nervous system. So in the peripherals, it's probably a little bit easier to penetrate through because it doesn't have this additional barrier. Right, so when we look at the toxic responses, it's actually divided into very specific ones, actually based on the effect or outcome of neurotoxicity. So as you can see here, so the first one is neuropathies, axonopathies, myelinopathies, astrocytes, and there's also neurotransmitter related ones, right? So it's actually very, very specific. So it's the stuff that we're going to look through later on as well. So again, if there's any impairment in terms of its neurons, right, in terms of the myelin sheath, right, which is linked to myelinopathies, on the axon, on the cells per se, so or on the neurotransmission. So all this will actually impact or have a negative impact on the efficiency of the nervous system function. Using a picture to illustrate the patterns of neurotoxic injury. So in A, in the first one refers to the normal one. The second one, as you can see, this is neuropathy. So the whole neuron is dead in a way, there's nothing connecting. So in C is axonopathy, whereby the main cell of injury is at the axon. So you can see some parts of here is gone, right? In D, as you can see, the myelin sheath, something is wrong. So in E is some toxicity due to interruption of the neurotransmission. So therefore, without proper signaling, so the the nerve sensory or transmission process is just out of the window. Over here is just some examples on the compounds which can cause neuropathy. So again, it's not just in the list for any other diagrams if you look at the examples for the whole video. So it's just an exhaustive list actually. So we're just extracting parts of it. So as you can see here, just to highlight, so for example, things like carbon monoxide, if you're more familiar with, right, which is the CO, so it can cause a delayed Parkinsonism and things like that. So it can be due to neuronal loss in the cortex and of the brain and so on and so forth. So again, every compound or every neurotoxicant is different, right? So in the second scenario of axonopathy, so again, this is just some of the examples of it. So you can see neuropathy, so there's axonal degeneration, so some can occur in the peripheral nervous system and also the central nervous system. So again, so it's sort of, lose the sensation in a way, right, because there's no transmission of impulse. Right, so these are some of the examples that can cause myelinopathy. So as you can see, the myelin sheath, it's damaged in some of the cases. So again, depends on which drug or which toxicant that we're looking at. So I'm not sure which one you're more familiar with. So things like amiodarone is actually a drug used for arrhythmia, so it can cause peripheral neuropathy. So one of the mechanism of toxicity is through, again, degeneration as well. Okay, so it's destroy, right, or the small lysosome activity in the Schwann cells. So again, one of the last in the list for the neurotransmitter-based toxicity. So you can see some of the names might be more familiar because these are some of the examples of illicit drugs, right? Like amphetamine, right? Cocaine. So it can actually cause tremor, restlessness, right? And things like that. So it just tapers with the system of dopaminergic, serotonergic and stuff. So there's also cocaine and things. So they might cause hemorrhage, which is bleeding and stuff. So the details of this, if you find this very alien, again, you read or you study more of it in your, I think it's in your third year as well, when you study more on the pharmacology and anatomy, physio and stuff on the nervous system itself. Okay. Right, so thank you everyone for staying until the end in a way. So I'll end this whole module with two stories. So these are very short stories. So the first one is gabapentin. So gabapentin is actually a drug, right? As you can see here, it's mainly used to control pain, right? Especially neuropathic pain, whereby it can be pain that caused by the virus that can cause chickenpox when there's another attack. So it might cause painfulness in the nerves. So gabapentin is one of the first choice as well. So this is a very recent news and article, as you can see here. I just saw it 2 days ago. Whereby gabapentin is actually increasingly implicated in overdose deaths. So what happens is that it may be abused. So I'm using this as an example because things can go wrong, especially for anything if it's being used under abuse condition, isn't it? So for gabapentin, as mentioned, it's a pain reliever. So alone, it does not affect breathing, even though if it's used at high doses. But the thing is, it can be used abused by mixing them up, right? By illicitly things like that. So they can mix with any opiate based kind of preparations and all, which then increases the risk very high by causing breathing depressions, right? So it just affects the brain, cause both of it cause the brain kind of depression, because there's a center, there's part of the brain that actually controls the breathing. So it actually causes too much reduction in the activity, therefore can cause death in a way, right? Because it reduces the breathing too low, the breathing rate too low, right? So this is an example whereby you might be looking at combination of substance. So sometimes it might be an additional effect, it might be synergism effect that can eventually cause toxicity. Similarly, like when we use combination drugs in the treatment to have a better clinical effect. But in this case, a combination treatment actually cause a stronger effect that may cause in a way side effects. Right, so this is a combination, but it has a very specific side effect. So the second or the last story that I'm going to talk about is paraquat. So this is the chemical structure of it. So you can see it's mainly used as a herbicide, right? So whereby it's used mainly in the agricultural. So you can see here it's very different from the gabapentin kind of example, because gabapentin, because it's a drug, so even you use illegally, it's something which available in a much lower quantity, right? But paraquat, because it's used in agriculture, so used in our oil palm field, and also the amount of it you can get is a huge tub. But bear in mind, it's something which is already banned in Malaysia currently, right? So previously it's available, but sometimes then we put it out. So why am I using this as an example? Because it's something very unique in a way, because it might be accidental ingestion, or it can be due to a purposely do it kind of so it's like you want to sort of kill someone and you put it in, so it's it's not so nice. Why is it tricky? Because it's a liquid which is a colorless liquid. right? It's colorless, so it's very difficult to detect. And the immediate signs and symptoms of this paraquat, if you can see here, if the person ingests large amount of paraquat, so you have likely to have pain and swelling, and things. Later you have, abdominal pain, and this is one of the organs. Remember, just now we talked about specific organ toxicity, but in this case of paraquat, it's actually a multi-organ toxicity, right? It can cause multiple organ failure. So again, it's an example whereby sometimes some toxic effects may not be so specific towards an organ, and the mechanism is more widespread in a way. You can see here, it can be confusion, it can be coma, it can be acute kidney failure. It's basically a very nasty thing because there's so many things, so many support systems being damaged, right? So there's a lot of repair to be done. So it's very, very tricky to reverse, or almost impossible. So even if the person survives from the toxic effects, so it can be long-term lung damage, right? And things like that. So it's very, very tricky. So they're most likely not to survive. So again, very complex mechanism. Why am I using this is because there's a case that I watched from the show. In a way, it's a reality show that I talked about on forensic stuff. So basically in that case, this guy, he was angry at his neighbor, so what he did, it was he actually put some of the paraquat. He didn't know it was so toxic, right? And passed it as like a cough medication. It was mixed into the cough medication. So these are bad examples. Obviously, don't do it. Don't do it, right? So what happened to him is that so he was taking, so suddenly when he was injured, and so he got more episodes of cough. So then the person started to take the added paraquat cough mixture, but because it took it as a cough mixture, so obviously you don't take so much cough mixture per day, isn't it? You'll be taking, spoons, and so on. So the effect of toxicity is not obvious as well. So it's just that his cough is getting worsened until in the end he was coughing blood and then he passed away. So only via forensic they realized that it's actually a case of forensic. It's a murder case in a way because it was added deliberately by the neighbor, but he didn't know it was so bad. And yeah, it was, but the effect, the clinical impact of it is more like a chronic toxicity that no one picked up, because remember, it's a colorless liquid and I don't think there's much taste to. A little bit of scenario in Malaysia. So basically we have a national poison center where you can do your attachment, industrial attachment over there. So basically it's a call center that everyone can phone for the public can phone for any inquiry, and it's also a center to collect data as well. So these are the paraquat poisoning calls. So some of it is intentional, like suicidal and stuff like that. So because it's so easily obtained, so all this data actually support in the end for the approval of its withdrawal or ban from the market, because you can find more expensive but other alternatives to be used as a herbicide. Okay, so this is one of the newspaper clips that if you're interested, you can go through them as well. Okay, so because it has a fast effect and it's a very effective herbicide, i.e. it kills all the weed around the plant that you want. Okay, right. Thank you so much for staying until the end. Yes, finally. Right, it's basically a big, huge topic, right, for toxicity. So therefore, I thought it'll be useful to record so you can watch parts of it whenever you are free or you're at the mood of it, right? So if you like the video and so on, you're welcome to subscribe the channel and to get more updates for the video. Thank you for viewing. And thanks for the likes and comments. All the best in your revision.